How are we doing, ladies and gents? Welcome to another nursing debrief with the Cup of Nurses. First week back after TravCon. We have worked 5 shifts out of the 7 days. It was a grind, 60 hours in the weekend and then Monday, Tuesday. A lot of great experiences, and we're going to share some of our best nursing stories, aka the worst nursing stories is what it really is. So yeah, Pete, how was your shift, man?
It was good, man. But it's funny because our buddy Renard told us that when we fly in and have that first shift at work, we're going to be like, damn, we're at work right now.
Yeah, at the Pyxis.
Yeah, at the Pyxis. And we literally flew in that morning and went to work that night, which was a mission. But yeah, tough. I had some tough patients, man. Definitely some tough patients. I had a very interesting case. So usually when you think of people going to the hospital, you think of something usually happening outside of the hospital, right? You think of maybe somebody having a stroke, an MI, a fall. Maybe they're going to DKA. But in this situation, things were a little bit different. So this patient came in for a permacath to get long-term chemo for the cancer that the patient was having. And during the procedure, very unfortunate case, what happened was whoever was performing the procedure nicked the right subclavian. And nicked right subclavian, caused a giant bleed, gave her a pneumothorax, had to be intubated and brought to the ICU. They put in 2 chest tubes. And it's crazy to think about that this was a complete accident. You can't blame a person that was doing the procedure because things just happen sometimes.
Consent was signed.
Consent was signed. Everyone's anatomy is a little bit different. This is going to happen. This is what happens every time. Same way in sports. People play sports and accidents happen. It is what it is. It's the deck you've been dealt.
Yeah. How was she doing overall? Because that was just an accident. Did she...
It was tough, man. I had her for 3 nights basically in a row, and it was just tough. Her main issue was she's very septic. She has a lot of different infections going on. She has a viral infection going on. She's on antivirals, and her main issue right now is her temperature regulation. For some reason, well, not for some reason, she's infected. She's an infection, so her temperature just randomly just shoots up.
What kind of cancer does she have?
I can't remember on top of my head what kind of cancer it was. But it was already, I want to say late stage, but the prognosis was already not the best. So her issue was temperature regulation. Whatever infections she had, it was just driving her temperature through the roof. And the thing with this is every time the temperature started to increase, she became tachycardic. She became hypertensive. Respiratory rate went up. O2 went down. And it's crazy because in nursing textbooks, the textbook febrile patient experiences all those. But nursing isn't always textbook. It's rarely textbook. But this was like a perfect textbook case of a hyperthermic patient. And we tried to put a cooling blanket on her. It would dip down a little bit, but then we would try to go on her sedation, and for some reason, that would throw her into a fever. So every time we try to change something up, for some reason, it just agitated her so much that she just got a fever. So her main issue is we can't take the sedation off. Because every time we decrease the sedation, runs a high temperature, and then you're in high risk for other issues. You could get a seizure, you get a stroke, you get a lot of problems can occur because you got a fever. So it's just like trying to manage a lot of different things. And plus, her platelets were super low. They were basically in the teens. I got her one night, platelets were 7. I gave her a unit, and the thing is, she had 2 chest tubes. Chest tubes are due to be pulled out, but the fact that she has low platelets, we can't pull them because then she's going to bleed out and there's going to be a lot of complications. So now it's like, hey, you leave the chest tubes in and have her be in a higher chance of getting another infection, or do you pull the chest tubes and risk the fact that she could bleed to death? Yeah. She had a really good urine output though, so that was real good. Also, they found a lot of DVTs. We actually had her in a Murphy sling just to decrease the swelling and the problem she was having with her left hand. First Murphy sling I've ever seen in my life.
Looked a little bit trippy because when I saw her from the corner of the room, it's every single time she took a breath.
Yeah.
It's like her arm was like waving at you, but really it's a sling that was just elevated up on her arm.
Yeah. And it sucks. And I came out of my last shift with her not having a good feeling. She just wasn't doing good. So I had 3 nights, like I said, and every night it got a little bit worse. So the first time I had her, I was like, for sure, let's try SBT, SAT. Let's try and get her extubated for the morning. And I was being super aggressive because I didn't know how she would react. And just, man, she was throwing fevers. Her heart rate was in the 150s. I was trying to go on her sedation. I was putting ice packs on her, cooling blanket on her to cool her down because I wanted to extubate her, but not realizing that this patient's fevers were this big of an issue. Because they tell you, yeah, we've been having fever problems, but this extent I've never seen it like this bad before. The second night, I tried to be just as aggressive, same issue, same thing. Went down to a little bit of sedation, already started getting agitated, throwing a fevers, tachycardic, desatting, hypertensive. So the third night, I'm like, all right, let's give this lady a break, man. I kept her at the same sedation. So just to let you guys know how much sedation she was on, she was definitely on a higher limit. Precedex was at 1.5. Fentanyl was 87.5. Versed was at 2.5. So still some leeway on those medications, but it's definitely on a high amount of sedation. And I literally went down, third night, I went down on Versed by 0.5. Our temperatures started going up. So this is like, it was wild to me. So I was like, screw it, I'm not messing with her. 2.5. I was giving her 1,000 milligrams of Tylenol every 6 hours. Or sorry, every 4 hours. I would change to every 4 hours just to manage something, because like once they started uptrending, you had to act quick. Once you hit like 37.4, you gotta get the cooling blanket on her. You gotta put the ice packs, give it Tylenol, because then she's gonna go all the way up to like 38.9 was the highest. That's crazy.
Yeah.
Yeah.
Poor thing, man.
Yeah, but how was your shift? You had some rough nights as well.
Yeah. Good old nursing, man. So I had a C19 case, which was one I didn't have for a while, so it was annoying gowning on and off. But I had a lady that came in for C. diff, was intubated for other things, ended up having abdominal pain and diarrhea. So we were trying to rule out a toxic megacolon on her because of the C. diff. So they were doing daily KUBs. And big thing with her is while she was intubated, she just threw up all over herself. Just did a whole bed change. Peter helped me out, actually. Thank you for that.
Man, I got you, man.
Started leaking all over, suctioned her out.
But the thing is, like, Darty wasn't there before and didn't do anything about it, you know?
Yeah, they didn't even do an oral care afterwards. And that's one thing that I don't like about this facility is that RT doesn't do the full scope of practice of what RT does versus other hospitals. You should be taking care of that mouth. Yeah. If she threw up, you should have been squeaky clean afterwards, man. But for me, it was the nurse's job here. So she actually ended up throwing in 3 different episodes, emesis. Same thing, intubated. Poor thing, probably had aspiration pneumonia. And then after the third time, I shut off her tube feeds. I shut off her tube feeds like the second time because I did is it called trickle feeding?
Trickle feeds.
Trickle feeds, yeah, just 10 cc's to see if her stomach could tolerate it. Ended up even during this time going into AFib RVR, became hemodynamically unstable, had to do some pressors, had to do an amio bolus, and that was like one of my nights with her. The second night we went in, there was an issue where she got extubated finally. I'm trying to remember the course of events. Cause I had 3 days. I had her one day, and then I floated again. Then I had her another day when I came back. She ended up getting extubated. The OG tube that I put into her mouth had to be taken out, but she was nauseous again. And what happened is day shift took out 700. So she does need to be decompressed. There's a small bowel ileus forming. What happened is they tried multiple times. They did a cord track device, which is like a ultrasound guided device where you could see if the Dubhoff is going in. They couldn't feed it in. She already had a Dubhoff in the left nair, but it was post pyloric, so that can't decompress the stomach because it's past that. So what ended up, a nurse told me this old-fashioned routine of putting a NG tube into the fridge for a bit, let it cool, and it's going to be easier to insert afterwards. So ended up going in there. I tried that right nair, which was open, complete resistance because what is it called? Trauma. It was already bloody. So went into the same nair, advanced it, got it in, perfect. Was able to decompress her stomach. She was just on room air during the beginning of my shift. Then by 3 p.m., she was so gargly, I had to deep suction her a couple times. Because of that episode, she went back into AFib RVR. She went from Neo on 2 mics all the way up to 9 mics. And what sucks about Neo is if it's on such a high dose, 9.1 mics per kg per minute is the max dose. You're running like a bag every 2 hours. So I had to like quad it up. Had to do another amio bolus on her. She was on a high flow, and overall she just wasn't looking too good. Yeah. So we'll see what happened. And then another shift that I had, so it's cool that we're kind of getting some ICU experience working in this facility, because a lot of times you're floating around, as you guys hear on our debriefings.
We floated our first 3 shifts right at the beginning of the contract.
We did. Yeah. And then the first 2 here were in the ICU, which is dope. I had DOU experience, so step down PCU observation unit. I had the max here technically is 3 patients. Can't say that word.
Kyle.
The hospital ratio. But if it's outside of their ratio going into state ratios, you get 4 patients. Anyway, the Chargers.
You got 4 patients that night?
3.
Okay.
Yeah, because we weren't out of ratio technically. So really bad charge nurse on day, didn't shuffle the assignment properly. And one thing about that is I understand that some nurses are coming back and they need their same patients back. But if the acuity changes, you need to shuffle that assignment around just so one nurse doesn't get screwed. This is what happened. Got a report. I had one patient that I got a report on. Within 15 minutes, IR was going to pick him up because he needed a right perc drain because he had a cholecystitis. We had to drain his bile. Okay. Was also getting a call from ER, which was a lady on BiPAP that was coming up to the unit. Okay, got a report. And at the 5-10 minutes later, they allowed me to take report because there's an ICU patient overflow that has to go to DOE because you guys need a bed because you were floating that day to the ICU. So in between my first 2 hours of my shift, I got 3 patients that came in. Yeah. As I was getting the patient from the ER, she was mucus plugging. We're suctioning her with IR, BiPAP. IR nurse is waiting for me to get report. They're trying to wheel the patient in. And then like 30 minutes later, my patient comes in from the ICU. I handled it. It's fine, but it's completely unsafe. And I was complaining a little bit to the charge where they need to be shuffling the assignment around. Of course, the charge nurse was awesome. We made it through, but it became crazy, dude. At one point, I forgot to like scan potassium, and another nurse helped me out. She's like, "Did you scan the first bag, or is this your second one?" And I'm looking at the MAR. I'm like, "Oh, I'm gonna back chart it," because I forgot about it because I was so in the flux of doing things.
Yeah, it's very unfair, man. It's rough.
Yeah, and I, of course, I feel like as a traveler, that's sometimes how they throw you in like that, where they love to give you a patient, they like to leave you open for admission, or during change of shift, you might be getting an admission or a transfer from the floor, whatever the case is.
They give you 2 open beds, though. That's pretty
2 open beds, yeah. I know. And there was another nurse that had only 1 patient after like 11 p.m. because one of her patients transferred out and expired. So it's like maybe you could have gave me something easier like the expired patient. Yeah. If you knew I'm going to have a patient going to IR, I'm going to get admission from the ER. But it is what it is, man. And then afterwards, things slow down. And then towards the end of my shift, I'm like, okay, I caught up on charting. It's like 6:45. I'm chilling, and that's when my guy went into SVT in the 150s. Like he was just hanging out like this, asymptomatic, just dreaming. And I'm like, hey man, what's going on? He's like, yeah, my heart rate's usually high because I have hypertension, but he's not connecting the dots. I'm like, no man. So I had to get a 12 lead. Showed that he has an SVT, and they're going to push some adenosine. But I didn't get to watch it because the doctor that was on, he wanted to get a consultation from pulmonary because this guy has interstitial lung disease. I had 2 patients with interstitial lung disease. Interesting. But because I guess adenosine affects the pulmonary tract, he wanted to be careful because he didn't want his lungs to get messed up. He was already on high flow, and they're working him up for the transplant list. So I'm not too sure what happened afterwards, but it was just crazy, man. Like it's all doable, but you're just so exhausted after your shift. Like you just sleep in and you feel like crap afterwards. Sometimes you don't want to do as much the next day because you got your ass beat at work.
But that was really cautionary by the doctor because people in Chicago or in Illinois, where I used to work, people would come with all sorts of lung diseases, all messed up in all sorts of ways, and we would still give adenosine. You know, you gotta do something. It's your dad or you.
You a cardio
yeah,
potentially.
Yeah, well, I haven't it's been a long time since I looked at what's better, adenosine or cardioversion. You know, because that's you can do both.
Yeah.
Did you have a pacemaker by any chance? You didn't, right?
No, he had a pretty good history. Everything was good. What's cool is I didn't know if you do a workup to get a lung transplant, they do a lot of things. They want to make sure you're vaccinated, like MMR, whatever your titers are. He had to get a cardiac cath. He went down to ICU to get a colonoscopy.
Everything, dude. Check your teeth.
He needed to get a DEXA scan, which checks like if you have at risk for osteoporosis.
MPEs.
No, it's a DEXA scan.
Lexi scan.
Yeah.
Okay.
The other one is a VQ scan to check for PEs. And yeah, it's, I mean, good for them, because if you're doing a lung transplant, I don't know how many lung transplants you could do a year, what the candidates are, but I'm sure it's scarce. So you have to be a good candidate. And of course, it affects their numbers if there's a transplant team in I don't know what hospital. If you're just transplanting lungs and the patients are bad or they have cirrhosis, your number is going to go down as far as success rate.
Do you know where he was on the list? Like a 1A, 2B?
No
classification. Yeah. Yeah, man. You do a lot, and then you get a bunch of labs drawn on top of that. But it's crazy because I know, because we get a lot of transplant back in Illinois, and it was always, for the first time I was like shocked. They actually check your teeth. They pull a lot of people's teeth before we give them LVADs, before we give them heart transplants, and it's just, that's the first time I really took in how important dental health is, because we all know brush your teeth to make your teeth white. It's healthy for you, but you don't understand how bad things could get with poor oral care. We literally had to pull people's teeth for them to get an LVAD or a heart or a kidney or a lung. It's literally that intense.
Yeah, perfect example is you could go get a dental cleaning or pulling a tooth and you could get endocarditis from that situation. So
is that crazy? Yeah. Since you're on topic of SVT, we had that one patient. They were transferred to a different hospital, but they ended up coding, not on our shift, but another shift. She had a pacemaker, but I guess she didn't have a defibrillator, and she did have. Now I'm a little confused, but I'm pretty sure she had a pacemaker and a defibrillator. The issue was her VTAC settings were set higher than the VTAC that she was having. So it was not able to shock her out. Yeah, so it couldn't shock her out. So this lady was completely 8 × 10⁴, talking normally in VTAC, but she did not reach the threshold of her defibrillator shocking her. And I had a similar situation with a patient back in Illinois. He had a defibrillator, but his VTAC was not triggering it because it didn't reach that threshold. I think my patient in Illinois was at like 160s, but they had him at 170 because I don't know really why, but and we couldn't do anything. It wouldn't shock him. So what we actually did was we did end up defibrillating him, because we're like, hey, what else could we do here? We got to shock him out of this, because he can't last with this forever. Long story short, we got reamed by the cardiologist and the pacer team, because what we could have done is we could have damaged that pacemaker, and it could have made things a lot worse. Yeah. But we were trying everything, trying to bear down, trying to put him on his side, cold water, trying to get him out of this VTAC, and we couldn't. So he was literally in there for like 15 minutes. So we're like, we have to do something. You can't just leave this guy. Physicians aren't picking up. The ones that are here don't know what to do. So hey, let's shock him. We shocked him. He got out of it, but still, people were super upset. But I understand why. At that point in time, I didn't realize how that could have affected it. It is what it is. But we had to get him out of it. So I don't feel bad. I don't think it was a bad decision, because how long was he going to be VTAC for until he codes, right? Yeah, you use your best judgment. All right, ladies and gents, thank you for listening to another debrief. We'll see you on the next one. See what else nursing stories we have as we continue our nursing contract. We have about 10 weeks left or so. Yeah. See you on the next one. See you guys. Bye-bye.